what happened is the plunger got stuck. And so when she was aiming it at the dapping dish and pushing, the plunger grabbed and then suddenly released all of the fluid, which means it shot into the dapping dish at high speed and turned right around and shot her in the eye. So I only know of this one accident caused by the person themselves who accidentally squirted their own eye and weren't wearing eye protection and very quickly ran water through her eye. There was no permanent damage, okay? But nonetheless, I want to encourage, whenever we use silver compounds, we want to have eye protection for our patients, eye protection for ourselves, and just be very cautious that if we were to get this in the eye, it could probably cause a problem. If we get it on it, and I've had wiggly kids, believe me, that it's a wrestling match to get anything done, and I've accidentally gotten SDF on a lip or on the cheek or wherever, and what happens is you get a little dark spot, and then as the skin exfoliates naturally, it just goes away. I've never had anyone say that hurt or anything like that. We just want to be as cautious and careful as possible, but realize that the only thing that we could get in trouble with is in terms of eyes. Okay. So these are some images that show the steps of isolating a lesion. And what you don't, over here you can see the air water syringe, but what we want to do is carefully dry that lesion. Once again, is you're preparing it sort of like a sponge so that the fluid will be absorbed rapidly. This is a microbrush applying the SDF to the lesion. And the recommendations are to apply it for up to 1 minute. Well, if your patient is compliant, that's great. But if you're trying to do this on a 3-year-old who has early childhood caries and is uncooperative, you've got seconds. So I'm just happy to get the tooth isolated and dried, apply, and then reapply the fluoride varnish as quickly as possible. This shows what the lesions look like when they're arrested. So what is an arrested lesion? We're still waiting for somebody to give us a really good definition, and I would like to have a tool that I can put on an arrested lesion and it tells me, is it arrested or is it not? We don't have that tool yet. We're very curious to see if maybe Diagnodent might help us in that way. We're doing some studies to find that out. But what we do notice is that an arrested lesion, number one, doesn't grow. That's what arrested means, okay? It isn't getting bigger. That's the first criteria. Second criteria is color change. So a cavity is generally brown, it has a color change. Well, now we have a dramatic color change. So think charcoal briquette. When it looks and feels like a charcoal briquette, it's arrested. So the two signs, the color, dark color, and the texture. So a carious lesion is often kind of soft and mushy, okay? And a arrested lesion is hard, like asphalt or like a charcoal briquette. This is what the setup looks like. Very simple. That's all you need. Cotton rolls, dapping dish, a mirror, and some product here. And fortunately, Elevate has dispensed SDF in a nice little bottle that is easy to just extrude one drop. And special thanks to Dr. John Frischella, who was the consultant that recommended that they package it in that product, which is much better than the product that we were getting from Japan, which was difficult to get the product out. So when would you use this? Well, in my world, it's hard for me to think when not to use it, because it's so effective in primary prevention. I mean, the fact that we put it on teeth that just don't get cavities later is just amazing. And no, we don't have really good studies yet that show that primary preventive effect. That's going to be coming, as time goes by. But basically, in my practice, if I identify caries, if I see a caries lesion, I want SDF right now. I'm going to get SDF on every caries lesion as soon as possible, treat it multiple times until it's arrested, and then restore the tooth in whatever way. I don't care whether it's a primary tooth or a permanent tooth. If it's caries, it will respond to SDF treatment very effectively. So there are categories of patients that are more susceptible to this disease than others, and certainly so high-risk patients like xerostomach patients. And in our population today, with increasing numbers of seniors, with increasing polypharmacy that they're on, we see xerostomia being a big problem. A lot of these folks have gingival recession, and they're developing root caries. And so we have almost an epidemic of root caries happening in America today. And so I can't think of a better opportunity to introduce SDF to control root caries and getting it into the hands of dental hygienists that are more likely to see these people early, the better. So I'm a big advocate of using SDF with our xerostomach patients, high-risk patients. So in addition to that, so patients who have management challenges. How hard is it to do a complex procedure on a 4-year-old that's uncooperative? And how often are dentists resorting to general anesthesia and sedation? We're seeing more and more tragic cases of this going in the wrong direction. And so silver diamine fluoride represents a way to stop the disease in some of these children, perhaps until they're older and they can tolerate the procedure better. Or patients with special needs, cerebral palsy patients, people like this, that allows us to treat the disease atraumatically, easier, quick, simple. So we can treat more than one lesion. I mean, in the old days, I would do a root canal and a crown, and it took me all afternoon. Okay. Now I can see 50 patients a day, and I can treat all of the decay in their mouth each time I see them. And so I'm not treating a tooth, I'm treating a patient, and I'm treating all of the disease that I see in their mouth at one time. So difficult to treat lesions. So I'm treating a case right now of very difficult to access root caries in a patient with Parkinson's disease, very difficult for him to control his movements. And so just getting to where the lesion is at is enormously difficult. So the ability to send medicine in there with a microbrush and stop it is enormously helpful in this particular case.
Focal reaction?
Pardon me?
Focal reaction?
Thank you for that question. So I've looked at an enormous amount of literature about, because everybody is concerned, what is going to happen to the pulp? And G.V. Black himself described a case in his book in 1908 of putting silver nitrate on a child's tooth with a big cavity and having the child yell, and he had to pull the tooth. Well, nobody had an x-ray. We don't know whether there was an exposure. I don't recommend putting silver compounds on an obvious tooth with pulpitis, okay? So, in any event, back to your question, for caries where pulpitis is not present, we've not seen any pulpitis. Now, histologically, we've seen that the silver does go through the dentin and can actually be present in the pulp, but it is not causing pulpitis. So when I first started, I was very cautious. I wasn't going to put this on anything anywhere close to the pulp. So I've gotten to the point now where my recommendation is if you believe there's at least 1 millimeter of healthy tooth structure between the lesion and the pulp, you can use it without any problems whatsoever. But I do not recommend if the tooth has pulpitis, either reversible or irreversible. If the nerve is unhappy, that's a separate problem. That means the bacteria are already in the nerve. Okay, so putting silver out here isn't going to help that problem. We need to do something else.
but yet it's made to reduce sensitivity.
Yeah, so
That's
I know
not
it's
smart.
a little paradoxical there, but it is very effective in reducing sensitivity, probably because it's blocking the dental tubules, okay? But I've not seen a problem with pulpitis. So the last point, patients with little access to care. So there are a large number of people in this country that can't afford to go to the dentist, or don't have insurance, or for whatever reason they don't go to the dentist. And what happens is the problem gets so bad that they show up in the emergency room. You have all these people flooding the ED and the physicians that don't know what to do with them. And so what we want to do is get the solution to them sooner. So our access to care populations, either Medicaid kids that could be treated at school, okay, or where they work and play and live, all right, and then the seniors that aren't getting access to care unless they have a serious event and have to be removed from the facility. So, and then we have populations at different ages throughout the country, but access to care could be addressed with the workforce we have right now. I'm not a big advocate of creating new professional categories. I think we have what we need right now. Let's just get the product and use it. So how often should you apply it? My cohort of people around the world who are looking at this very carefully, we're all pretty much in agreement, and G.B. Black actually mentions this in his book in 1908, that it's unlikely that one application is going to work. You may have to do more than one application, and G.B. Black recommended applying and reapplying until you have a rest. So until the lesion is not growing, until you have hard, dark surface, etc. So pretty much we all agree that 2 or 3 applications are necessary. Does that have to be every day for 3 days, or can it be once a week? Nobody knows for sure. In my practice, we've evolved so that we're now treating once a week for 3 applications, and we're seeing 95% success arresting lesions. I used to do once a month for 3 months, but I've just found that it seems to be more effective if we collapse that protocol. And we'll have more information coming out about the exact protocol, but the point is, if we don't use it, we're not going to figure out the best way to use it, so we need to start doing that. So with respect to, I think I've gone over some of this information, so the safety of the product is remarkable. We need to be really careful about this. Although this particular image, I think, is representative of, they used silver nitrate early on as an antimicrobial agent for newborns. So, I mean, the idea of putting silver is a very dilute compared to what we're using for caries. But they used to put silver nitrate in eyes purposely. So, protect yourself. You don't want to have this happening. This is what the lesions look like. These are actually from my office. This is a child with early childhood caries, active, and then this is what the arrested looks like. We'll talk some more about what to do next. I mean, the biggest criticism is, oh my gosh, it turns the teeth black. That can't be a good thing. Well, I don't want to get misled by that. It is turning the lesion dark, and that's an indication of success in arresting the lesion. And we don't have to leave it like that. We can cover it up. We can restore it. There are a lot of things we can do. So we're not trying to avoid treating the patient properly, not at all. This shows the evolution over time of some facial lesions that are arrested.
So when you have an alloy restoration and you remove it and put a composite resin, you still see a residual alloy margin. Do you still see a residual silver margin?
So Yes, that's a very good example. And I suspect when you remove an old alloy and you see that dark area, that's really silver from the alloy that is leached into the tube and is there. Now, so what happens if you skip that step and you put SDF in there, then boom, it goes right in the tooth right away. So what happens is you're gonna have, if you're trying to do a cosmetic restorative procedure and you're gonna have a silver step, then you just have to think about the color change. So what I'm recommending now is if you're arresting the lesion first and then you're doing an aesthetic restoration, simply choose a product that covers up the darkness. So a glass ionomer cement with opaquer is very effective. The product we're using right now from Shofu is Beautifil, which is a resin-modified glass ionomer cement with opaquer. It's really easy. I'm going to show you a video in a minute of us using it. But the point is you can cover that up. Here's an example of some lesions that are arrested. Okay? This shows a lesion that was arrested and then glass ionomer cement was placed into the cavitation, and you can see the darkness around. It's the silver halo, and that's exactly what you're talking about. That's the silver still there. Now I look at that and I think, all right, I know the silver is there. I know it's the zombie effect is going to protect that tooth. Now the restorative dentist would say, that's ugly. I don't like that. So anyway, it's a primary tooth that's going to come out. Here's a kid with some anteriors that were covered with Beautifil, and he's got his nice smile back. So we can fix the discolored, and what we're calling now smart fillings, silver modified atraumatic restorative technique. SMART is the acronym we're promoting now, where you arrest the lesion and then you restore with a glass ionomer cement in an atraumatic manner, and you end up with a nice aesthetic result as well. So some take-homes from Dr. Horst. Again, this is greater than 90% effective. This is so much better than anything else we have. It's silly even talking about it. I mean, it's like night and day. It's just amazing how effective it is. It has a powerful indirect preventive effect. So when we put it on teeth, we're preventing other teeth from getting cavities. It's quite remarkable. And yes, it stains everything. So just be ready for that. Dr. Horst spoke there. So I want to play this little video for you. Claire. But I'll explain in advance. The first part of the video is when I met Claire 5 years ago, when Mom brought her to my office from Utah to prevent her from going to the hospital for general anesthesia. And then we see her again 4 years later when we needed to cover up some of the dark spots so Claire could go to school. And we get an interview with Mom at that point in time. And I'm happy to say that today I received in the mail 2 of Claire's front teeth, which have now exfoliated, that were scheduled for pulpotomies and stainless steel crowns 4 years ago under general anesthesia. And we'll be sending those teeth to Berkeley to study them under the high energy physics. What time is it now?
8:18.
Okay, is that good? We're okay.
Well, good morning. We're here with Christina and her daughter Claire, and we are grateful you're here to receive dental care at Shoreview. I'm curious if you just tell us your story about how you found us.
Okay, my pleasure. So we actually just moved from Salt Lake City to Seattle, and so we're not locals, and we did search this practice out. When my daughter was about 6 months old, she already had quite a few teeth, and I noticed some yellowing on her teeth. I was night nursing, and she'd started solid food, and I asked her doctor at that time about the yellowing, and he said, it's nothing, don't worry about it, you're just being a nervous mom. So I didn't. And then at 12 months, it looked significantly worse. And I made an appointment with a dentist and also saw her doctor again, who still said, it's fine, don't worry about it. Later that day, saw a dentist who said she has severe decay on her forefront teeth and she needs crowns across all forefront teeth. And that it would be performed under either, let's see, general anesthetic or, I think, is it unconscious sedation? Conscious sedation. And with a background, I've got a master's in molecular biology, and with a background in working in the drug development industry, I wanted to understand the drugs that were being administered, that would be administered to her, and the further I got into it, the more concerned I got. Between the Mayo Clinic epidemiological study that showed the association of, the association between people who'd had 2 general anesthetics before the age 2, and I think it was a 37% incidence of a learning disorder, and then, you know, a lot of what seemed like hand waving to me about, well, it doesn't show causation and so forth, and that's fine until you look at the monkey studies on 5-day-old monkeys. I can't remember if that was propofol or ketamine, but it clearly showed neuroapoptosis during synaptogenesis. Same in the rats, and I think there's reason for real concern. So I started really digging for an alternative and found the use of silver diamine fluoride in other countries, and read a paper that said there was something like an 80% success rate in rural China. And I thought, well, you know, if they could get 80% in rural China, I think we could probably do better than that with better monitoring and things. So, so I pursued that. My dentist hadn't heard of it. Someone from his office at the time, the office manager actually called me one night after I canceled the procedure and told me that my daughter could die, that the infection could go systemic and she could die and there's no alternative, and did I really understand how serious this was and that sort of thing. So it was a really traumatic experience to be faced with this choice of what I read in the literature and brain damage versus you know, a risk of dying, and which is not a good choice. And so I was quite happy to find someone in the United States practicing the equivalent of the silver diamine treatment, or something similar to it anyway, with the silver nitrate and the fluoride varnish. And we haven't done an x-ray in the last couple months, but she was still going back to that other dentist and having x-rays, and after, I think it was about 4 months of treatment, there was no progression at that stage in the decay. And so they were actually quite intrigued. I haven't been back to that practice recently, but I think things are pretty stable and doing well. So.
Well, thank you. It's a fascinating story. And with a scientific background, just does it make sense to you to approach this with an antimicrobial solution rather than just needles and drills?
Well, I mean, it's craziness to me, really, that the whole practice of dentistry seems to ignore the underlying disease. You know, that there's an infection, essentially an infectious disease that can be approached, you know, once you have active decay, something like the silver nitrate. But even prior to that, I mean, they say like, oh, you shouldn't give your kid a lot of sugar, but I mean, there's so much to changing the bacterial strain that I think, or the, what do you call it, the karyogenic strains that are in the mouth, and changing the flora in the mouth. And, you know, nobody pays any attention to any of that. And so I think there's really a need in the field to do something besides just drill, because that doesn't impact the disease, really.
So we really are going back to basics, and it was astonishing for me to discover that dentists 100 years ago knew that this was a bacterial infectious disease, and they were using medicine to treat it. That medicine being silver nitrate. Silver diamine fluoride is a more modern iteration of that, but is not available in the United States. So in any event, it's a delight to have met you and your daughter. We hope that we can arrest this disease, prevent it from progressing, and allow her permanent teeth to come into a healthy mouth.
Right, yeah, thank you very much.
Thank you very much.
We're glad we found you.
Great, thank you.
Because we don't want it to be dark, because you are a very pretty girl, and we want you to have very
So
pretty
this is
teeth.
4 years later, treating her in a kitchen. We're simply covering a couple of those little dark spots so she can go to school and smile.
This last week for a few days when I was brushing her teeth.
Some anomaly, just, those are normal, that's absolute, there's no depth to that, there's like, look at it.
That's Dr. Michelle. She's probably done more
So this
cases
is
than
38
I have.
plus where
But
it has
we're
to
neck
be
and neck.
judging it. For about 10 seconds, okay, just so that we can penetrate it, and the reason for that is that we're trying to get a little bit more porosity. So I look at the arrested caries as being the consistency of a charcoal briquette. Okay, so think of this as penetrating the charcoal briquette and opening even a little bit more porosity into that briquette. Okay? Then this is bonding agent that penetrates the porosity and goes deep inside and on the surface. Then this bonds with this together, and we get micro-mechanical locking into the porosities in the surface of the charcoal briquette. And it's only massive, that's all. Okay. So it's actually purely cosmetic. Okay. Oh yeah, are we gonna use air? If we're gonna use air, we should talk Claire, I didn't even know we were gonna use air.
We can.
I think we dry it with this.
You don't think we need air?
No, I think we dry with this. Okay, it just makes sense.
Notice we didn't need a dental office
Okay,
at
can you
all
bring your head back?
to do this.
Here we go. Okay, now, the first thing is the cotton roll. Okay, and what that does, I'll show you, okay? Okay, keep your hands up. We are ready? Cool. How's that? Is it okay? No? How we go? It'll only be a minute. I'm gonna do this one on this side first, okay, Claire? Try not to push that with your lip, okay? You're doing good. I won't push hard either. I put the two so on. Ready? Here we go. Now let's have this. Okay, now wait. I gotta wash it. Ready? This is just some water. Okay, that's all this is. Just water. Good girl. Oh my goodness, you're doing so good. Now I need to dry it. Okay, I gotta dry one of those. Maybe this one's good. Okay, hold on. Here we go. You are doing so good. What a good girl. Okay, now can I have my bonding agent, please? Awesome. Make sure I get it real dry. Here we go. Okay, now I'm gonna put this on. Don't move, okay? Hang in there. Good. Now, hold on, I get a little bit too much. I don't want too much on there. Just one enough. Good. Dr. Steve's coming. Set the light on it. Go ahead, you do it. He's putting the light on. You okay? Everything good? Oh, you've been such a good baby. You're just awesome. I'm so glad I got a chance to meet you finally, because I heard all about you. Now I'm using the paint, okay? And I'm spreading the paint on. Good girl. Nasty black scar. Isn't that cool? I mean, it's not real translucent. It doesn't look like a real tube. It looks more like a chiplet. But that's better than black. The way I'm looking at it. See how I'm spreading it on my mouth? That's sweet.
I'm gonna go forward just a little bit in the interest of time.
us a little bit about this most recent trip out to see us and what we did and how it caps up the treatment that you've selected for Claire.
Sure. So, Claire is now 4 years old, and we started this when she was 12 months old, and she had a little staining on her front teeth from the treatment, which, well, you know, before school started and things, wasn't a big issue for us really, but as she gets older, I was a little bit more concerned about the social side, and so we decided to do this procedure to cover up the staining with the white, I guess, glass ionomer resin. And so we did that, and can you smile? Want to smile? Yeah. So we're happy we made the trip. It's kind of finished this little journey for us, which has been a worthwhile one. We managed to avoid the general anesthetic and the sedation drugs, which was really important to me. With you know, the possibility of doing some damage to the heart.
So these are the teeth that I received earlier today. And so we will be sending those to Jeremy, who will be studying them. And I didn't mention this, but Jeremy was in the background while we were treating Claire. He actually came to, we were in Redmond, he came from San Francisco to Redmond to watch John Frascella do that treatment. And has been following this case very closely, and so this is a special story. This is Lawrence Livermore lab, and where all of this equipment is, where they're going to be studying these teeth, so that we can understand what's happening. Question.
Well, you said one of the first steps was to clean it, but I didn't see any cleaning in that procedure.
So these were anterior facial lesions that were clean. There was nothing there.
So it's just a gross debridement. You don't have
Correct.
to go in and just,
No.
okay.
No, you just
want to make sure there's no
Correct.
big changes.
Yeah, so really quickly, so one adult patient, Robert, was a stroke patient of mine. This is not a picture of him. I wasn't smart enough to take a photo before. You're gonna see the after, but those of us that treat these folks, we see this every day, don't we? Okay, we know what this is like. When a patient cannot brush or floss their teeth and have no care, this is what his mouth looked like. And I had been treating him for some time. Every 3 months, we would blast all that stuff off. We would find new cavities. He had, you know, extreme gingivitis. He had all kinds of problems. And in about 2009, we decided to try SDF. And I explained that your teeth might turn black. Okay, we don't know what had happened, but should we do it? So this is a photograph 3 months later. He came back for his 3-month exam, opened his mouth, and this is what I found. And I immediately said, "Get my camera." Can't believe what I'm looking at. He had no plaque on his teeth. Look at his gingiva. Okay, there's recession there, and he eventually lost these two guys because of bone loss, but I said, who's brushing his teeth? Nobody. Nothing had happened, except we put SDF on this guy's teeth 3 months earlier. This dramatically changed the microbiota of the mouth. And so I went actually about 3 months ago and I interviewed him at home about how he felt about this treatment. So let me play this short little video. So Robert, we've had the pleasure of having you be a patient of 7 years now. You started coming to visit us in 2007. And so I would like you to tell me a little bit about your situation in 2007, how your health was, and how you were dealing with oral hygiene and brushing and flossing your teeth.
Well, it's hard for me to brush teeth because of the Parkinson twitch. But back in '07, I was having a lot of cavities and pain in my teeth, and so I was constantly going in and getting cleaning and having that nitrate medicine put on. And now I don't have ever have any cavities, and the pain is totally gone.
Wow. So I remember we started treating your teeth with silver compounds in 2009, and we noticed a big change in the number of new cavities that you developed and the healthy condition of your gums, etc. And so I'm just wondering how you feel about that. Are you happy with this new situation?
Yes, I am. It's, a way for people that have a difficulty in brushing or in maintaining. It's another avenue of getting your teeth, the gums taken care of.
Fantastic. So we're gonna cut because I think maybe it stopped. No, it's still rolling, okay.
Sorry about that.
So,
Editor.
Robert, do you think that this method of treating tooth decay and improving gum health would be helpful for other people?
Yes, I do. It definitely will help them in a long way.
Is there any downside to this? Anything you didn't like about the treatment?
No, it's been all good experience.
So do you think it's better to paint medicine on your teeth instead of get needles and drills and?
Oh, by all means.
Well, we're really happy that you're part of our family and our practice, and happy that you're doing better.
Robert was a happy camper. So real quickly, what we've been doing now is trying to figure out how to translate what we learned to a larger format. We were invited to go to Ecuador about 2 years ago by the Ministry of Health, and Kelly was instrumental in designing this pilot that was conducted. We went to a rural school just outside of Ibarra and treated close to 200 children in the school and also in a special needs facility in the hospital. And then we've tracked this data very carefully over a year and gotten close to 90%. This will show a treatment going on real quickly. This little device here is the device that we invented that makes it easy to put the silver compound and fluoride virus compound in rural settings. And Marcus right there is the guy who invented it. So anyway, you can see the doctor is drawing the lesion, then we're applying silver compound, and then applying fluoride varnish immediately afterwards.
¿Listo, Fernando?
Yeah.
Okay.
So once again, in Ecuador, we had 95% success. It's just amazing. And Ecuador is trying to figure out how to take this throughout the entire country.
Did you stay for 3 weeks so that
Yeah.
you could, okay.
Yeah, we stayed there, and then we went back at 3 months, 6 months, and 12 months.
Nice.
And we're getting ready to go back at 24 months for 2-year data collection in Ecuador, which is going to be real interesting. This is in Ghana. I want you to take a moment, just pay attention to how many children pile out of this school bus. Okay?
Like a clown car.
Should have seen it in person. It's very entertaining.
Goodness.
It's an amazing school with 300 children that we treated in rural Ghana. Ghana is a country of 27 million people and 250 dentists.
Oh my God.
Talk about an access to care problem. There's none. So we need to come up with something different for this population. It was really a wonderful experience to go to Ghana. This is again a video showing a little close-up of the treatment.
Because I noticed not all of
Just
them.
genetic,
Okay.
there's just more melanin. Why you want to go?
You're going to do that. You're gonna start.
Yeah, you're gonna
I
start something.
don't do it, Marcus. I did that the other day and then it was chaos.
Sorry, Tiffany.
Should have been more careful about what we were saying in the camera.
That's my bad.
That was Marcus.
That's my bad.
Exactly. Okay. So this is Dr. Amma, a Ghanaian dentist who was trained in the United States, University of Michigan. W.D. Miller's. She's gone back to Ghana, and she's now helping her patients throughout Ghana by using our device. So again, our preliminary results, greater than 90% success for arresting caries throughout the lesions throughout the country, and improving access to care. So one more thing in our story. So I want to tell you about Jackson. Jackson was 3 years old when he went to the dentist, and these are the x-rays that show the lesions that were identified on L and S. And you might need a magnifying glass, but you might see them actually. So Jackson was treatment planned for 2 resin restorations on those 2 teeth. And he was also scheduled for a oral sedation, because he's only 3. He's probably not going to cooperate, right, with needles and drills and things. So the drugs that were suggested for the oral sedation for this 3-year-old child: hydroxyzine, demerol, chloral hydrate, nitrous oxide, a papoose board, okay? And so that's what, this is not him. I pulled this off the internet, okay? This did not happen, but this does happen. We know it happens, okay? So once again, what are these drugs? Demerol. Can you think of a more dangerous drug? Demerol, okay? Chloral hydrate. Does anyone know what chloral hydrate is? Nobody does. Okay, it's an old ancient drug that nobody understands what it is and what it does, and there's no reversal agents, etc. Hydroxyzine, nitrous oxide, local anesthetic. In order to do that, surgical intervention of those tiny lesions. Okay, so why should we not do this? All right, it's a very important question. Well, this is why. Okay, at the same time, 2014, when Jackson had his exam, this child, 3-year-old little girl, went to the dentist for some fillings, had demerol, hydroxyzine, chloral hydrate, nitrous oxide, local anesthetic, and she died. Okay? We continue to hear about children that are dying because of complications of sedation. This is serious, and it needs to stop. Absolutely needs to stop. So, we can save children from this kind of an outcome using the product that we have available to us. This is the better way to go. I'm happy to show you that we decided that we could treat Jackson's lesions a little less invasively with silver compound. And so here's Jackson with his brother and Julian, and this is Julia, and Julia's right there. She's here with us tonight. Okay, this is Julia with Jackson and Grandma treating Jackson at home. Okay, and what we're doing is just flossing some SDF into that little interproximal area. Very simple. All right. And so there's Julia and Jackson. And by the way, we took these x-rays recently, and not only has there been no progression, but there has been a remineralization. Absolute remineralization. So in my view, we have cured Jackson. By the way, Jackson is my grandson. So thank goodness, when people criticize me that this is a lower standard of care, no, it isn't. My grandchildren get this standard of care. This is the best standard of care we have. So, what are the next steps? If you have not tried SDF yet, try it. It is within the scope of practice of your profession. Get it. Try it. Be conservative. Try some simple ones. Don't try complex cases, okay? But try simply. See in your own hands and eyes what this can do. Carefully document your cases. Share your information with colleagues. I think the fact that this is a product that can be within the scope of practice of dental hygiene is the greatest hope for us to address the access to care problems in America today. There's no question about that.
You can make a difference.
You can. So once again, I want to thank you all for inviting me here tonight. And are there any questions that I can handle before we wrap up? Yes.
About the 500 one-drop applications, is that a lifetime thing, or that means like in one sitting?
So the LD50 toxicity range, the 50 times, suggests that that's happening in a short period of time. Yeah, so I can't imagine anyone getting 500 treatments during their lifetime because we know we can arrest all the cavities in 3 applications. But I'm pretty sure that that's associated with an acute exposure, not chronic exposure. Yes,
Can I share a story?
please.
I just wanted to share some of the experience that I had with silver diamond fluoride. I was very lucky to meet Dr. Duffin probably 8-9 years ago, and he actually gave me silver nitrate, where I was able to apply, and I was doing the silver nitrate with fluoride varnish, which then very quickly the dental board took that out of the hygienist's hand. So now I had something that I loved, it was working, and I was frozen. I couldn't do anything until finally silver diamond fluoride came onto the market and was approved. And even when it was approved, we still had to wait till it was available. And so a bit ago, I was treating my sister, well-educated, cleans her teeth really well, but she still was having irritated tissues, mild to moderate inflammation back in the molars, so she obviously had some bacteria that was irritating it. And I said, oh, we have this product that we can try, and she had sensitive teeth. And she said, no, I don't want it, it's gonna turn my teeth black, absolutely not. And so I reminded her that it only turns decayed teeth black, it will not turn healthy teeth structure black. And she said, well, will it? I said, it only turns decay, and if so, that means you have something that you need to get taken care of before it gets any bigger. So I talked to her, she agreed, we put some on. 3 months later, I checked out her mouth again to do another cleaning. The inflammation was gone. So she had some bacteria that was causing the problem. And I was very careful, to keep it in the molars, didn't put anything on the anterior teeth. The inflammation went down, she was back to pink, healthy teeth. We reduced whatever bacteria was causing the problems. Nothing turned black, great, she didn't have any decay, and if it did, we knew she needed treatment. And I asked her, I said, how's your teeth sensitivity? She says, what are you talking about? I said, you told me your teeth were sensitive. She goes, oh, yeah. She completely forgot that she had sensitive teeth because it took care of the problem. I have 2 sisters, both with sensitive teeth. Both of them came back, completely forgot that they had it. It was taken care of. So it's not just for the special needs. It's not just, it's for everybody, picking the right cases. My father has Alzheimer's. I have been treating him every 3 months. He had immaculate home care, never had any problems. As his Alzheimer's advancing, decay after decay, root caries everywhere. My mom's now looking at treating 20 different sites and the cost and the expense of that. 3 of them, we sent him in to get taken care of because the items were structurally, the tooth was structurally unsound. It needed to be addressed or the tooth would have broke. All the other sites taken care of with silver diamond fluoride. Huge expense that was spared by my mom. And every 3 months I reapply it. He has healthy gums for a man who can no longer take care of his teeth. Several people I've been taking care of in nursing homes, and all of them, you can tell they can't talk to themselves anymore because the ones I've been working with have been dementia patients or Alzheimer's patients. But if they're not eating, if they're pulling at their lip, if they're pushing at their face, there's some pain, there's some discomfort. And with the people I've been working with, that's gone away. They're eating healthy again, and I'm seeing pink tissues. Yes, I'm seeing black. But for the last year of my patients that I was working with, the last year of their life, they weren't in pain, and they're patients that couldn't make it to the dentist and their family isn't taking care of 5, 6, 7 cavities at every visit to the dentist when they do get in. So many, many advantages.
Were you able to isolate,
Okay, Kelly.
can you isolate those dementia patients? I mean, the
Yes.
application, you just dry it off and,
I have, from what Dr. Duffin, we have a pump system where I can pump up a bottle and I use air if I don't wanna do my whole setup. Or I do have a mobile setup where I go in and I can, clean their teeth and, or do the spray. So yes, I can isolate and dry.
Do these have to be patients of record of whatever dentist we're working for?
I'm an expanded practice dental hygienist, so they are my patient of record.
Okay.
But, some of my patients, were patients that were in my regular dentist practice, and then they have advanced into care centers, so they were his patient of record, and I kept them as his patient of record, and kept all the notes and stuff at his office, and just brought their chart with me, and treated them as his patients. So if the, because for me, I don't have enough patients to bother with doing billing and stuff, but if they were the dentist that I work for, his patient of record, then they can do all the billing and stuff for them.
I guess the message is collaboration. We need to work together on this. Yes.
Do you ever use potassium iodide?
So the potassium iodide story. So a company in Australia has suggested that you can mitigate the color change by placing potassium iodide after the silver diamine fluoride. And that's because you form silver iodide, which is white. And what happens though is it sequesters the silver ion. And so you get a color change, but then there's less silver available to kill bacteria. So I've looked at this carefully just from a microbiological standpoint. It doesn't make any sense to me to eliminate silver from the equation. I've used it clinically, and yes, there is some color change, but it doesn't fix the problem. It's better to cover the problem up. So I'm not a big advocate of the potassium iodide.
Is everything on your website too with like step-by-step instructions and maybe even like some videos on how people can apply it? It's great hearing you say all this, but to actually go out and do it myself, I wouldn't.
There are hundreds of people in America that have done nothing but gone to the website, watched the videos, and are doing it. So it's really very straightforward. If there's anything there that you don't find that you want, let me know. Yes?
So in cases of extreme sensitivity where they're sensitive, there's exposure, surfaces due to recession, and caries at the very bottom, you're not seeing any leaching above only that specific caries site. There's no staining above it.
We've actually seen darkening in other areas of the mouth, so we think the silver ion is moving with saliva to remote areas of the mouth and actually exposing some demineralization. But your main question, I think, with respect to the pulp. So if you think the pulp is exposed, don't put it anywhere near it. If there's frank pulpitis, they need some pulp treatment, not SDF. Over. Yes.
Once arrested, can you treat it with the silver diamine fluoride? Do you see recurrence of caries and other signs of it?
Very good question.
Or around where you are arrested?
So the question is, do you see recurrent caries after silver treatment? So with conventional restorative care, the biggest problem is new caries around the margins of the restoration. We just don't see that with SDF. I mean, when an arrested lesion becomes arrested, I could count on one hand the number of times that lesion has become reactivated, and it probably is because there was a deep aspect that did not get treated with the SDF. And then the second issue is with respect to the protective effects. So we also see dramatically less cavities in our own patients in our practice, and other clinicians that are studying this are seeing this effect as well. I encourage you to go to our website and watch the Canberra video. It's the entire video of the SDF presentation in Denver, especially Jeremy Horst's presentation. He speaks to this in great detail.
What's your website? Yeah.
mmclibrary.com. Yes. How much do I charge? Yes. So we now have a code, and so I think our fee is about $25 for one application. And so what that means is if we're going to do 3 applications, it's about $75 to arrest all of the lesions in a patient's mouth. And for some people, that's the end. We're done. Good.
So compared to how much it costs to drill and fill, price-wise?
So this is a greater than 90% reduction in cost. 90%.
There you go.
Better for the patient. Grooves of permanent molars where you might otherwise put a sealant or?
So excellent question. And what we're kind of looking at right now is that can we do combination therapy? In other words, on deep grooves of molars that we're going to seal, why don't we put SDF down first and then a GIC sealant on top of it? I would never put a resin on top of SDF, but we routinely do GIC sealants after we apply SDF. You have like 2 protectors there.
Is it because of the light curing exacerbates the stain?
Correct, exactly. Whenever you put light, it's all the silver compounds are photoactive, so when you get ready to cure your resin sealant, boom, that darkness shows up, and we don't want that. So if you use a GIC, self-curing, then it's not going to happen. Yeah. Which is great.
So if a young child has had this treatment done, what's their risk for future caries? Does it go down at all?
So we believe it's true. So it's being studied right now. There's very strong evidence that by stopping active caries, we eliminate the risk of future caries. Now, we've been treating a lot of patients that started when they were 3 and 4, and they're now 11, 12, 13. Their permanent dentition are coming in, and we're trying to see if not only we can eliminate active caries in the primary dentition, but can we eliminate it from transferring to the permanent dentition? We'll see. Ask me in 10 years. Yes?
So if you can't do 3 applications, is it worth doing 1?
Yeah.
Or stopping?
Nobody knows what the number is. I mean, G.P. Black said you probably need to do it more than once. He didn't say do it 3 times at 3-week intervals, and we've been experimenting. If you are somewhere and you get a chance to do it once, do it, rather than not do it. We have some people that are kind of going on mission trips, and they're going out in the field, and so they get 1 shot. So if you get 1 shot, what I recommend is do SDF and GIC. SDF and cover it with GIC. Don't worry about the fluoride varnish. Just put GIC right on top, and then you've really, sealed it in there. Yes?
Wait, is the special instrument that was devised, is that for sale?
Okay, so the no decay, thanks for no decay that we talked about and showed you is not available in the United States. And I don't know whether it will become so. I mean, it was really designed for the developing world, and that's where we're promoting it, so I don't know. But we're here to promote Elevate. You can get the product from that company. Yes?
What was the code again?
Code 1354.